If you are worried you have Lyme disease, or just like the outdoors, and want the peace of mind of knowing whether you have Lyme disease or not, there is a new Lyme screening test based on decades of research by Dr. Richard Marconi, a professor at VCU Medical Center. For more information, visit glymedx.com, that's glymedx.com, or email at info@glymedx.com.
Infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, September is Sepsis Awareness Month. And with all the craziness that's gone on this month, I wasn't sure if we were going to get to this, but fortunately, we're going to be able to jump on it on the last weekend of September. I really want to go over this topic. It's really, really important. And I have an excellent guest to talk sepsis with. So joining me now is infectious disease physician and returning guest, Dr. Stephen LaRosa. Dr. LaRosa, welcome back to the show, sir.
Hello. Thanks for having me back.
Yes, sir. Well, let's really dig into the topic of sepsis, and I want to start out with a definition because a lot of people in the audience may not really know what it means. So what is sepsis?
Yeah, so a lot of physicians use the term loosely, too. So sepsis has undergone a change. It initially was described as a hyperinflammatory response to infection that led to organ dysfunction. However, we realized that the immune system can be both activated as well as suppressed, and it's really a dysregulation of the host response to infection that leads to an organ dysfunction. So the current definition is life-threatening organ dysfunction due to a dysregulated host response to infection.
Now, when we hear the terms sepsis and septic shock, are they synonymous or are they different?
So septic shock would be considered a subclass or subgroup of sepsis. So sepsis has to have an organ dysfunction, and when that organ dysfunction is the cardiovascular system, namely a low blood pressure, less than 90 millimeters systolic, mercury systolic, that doesn't respond to a fluid resuscitation, that is septic shock, and that's associated with the highest mortality.
Yeah. Now, this is really a big healthcare issue. And as far as numbers, the number of people affected and the cost in dollars, and what is that in the U.S. annually?
Yeah, so there's been a nice study with updated data published in JAMA, Journal of the American Medical Association, run by the CDC, and they had some updated numbers, which is helpful. So about 6% of hospitalized patients actually have sepsis. The associated hospital mortality is about 16%. And in terms of when you take their data and you extrapolate, it's about 1.7 million U.S. patients with sepsis a year. And in that population, it's about 270,000 deaths. So doesn't quite get the press of a lot of other problems and conditions, but certainly is devastating and costs in excess of $24 billion annually. And the incidence is increasing. Fortunately, we're making strides and the mortality is decreasing.
6% of hospitalized patients have sepsis. I didn't think that.
Correct.
That's really high. Did that surprise you?
That was surprising. It was, but again, it goes to speak to the magnitude of the problem.
Yeah. Okay, you're an infectious disease physician, and I imagine you treat sepsis patients. What symptoms do you typically see in a patient with sepsis? Yeah,
so sepsis does not have a specific presentation, but there are clues, and the clues have to be picked up on. Certainly if somebody's having high spiking fevers and rigors where their body's shaking, that can be associated with bacteremia. But there are other things that just by a close observation you can pick up on. One is an elevated respiratory rate, so somebody who's breathing more quickly than normal. Diaphoresis, where they've had a drenching sweat. And one of the most telling and early symptoms is a new altered mental status. So this can either be in a young, previously healthy person or an older person where suddenly their mental status is off. It's a very early clue to the presence of sepsis. Again, by observation, there's a condition called libido, which is a vascular condition where they develop basically a lacy appearance of blood vessels on their skin as the blood vessels become constricted. The patient can become cold and clammy. There's a subgroup of people with sepsis who develop what we call disseminated intravascular coagulation, where you can see clotting in their skin, on their face, on their ears, on their toes, and their fingers. That's a small group, but these are all clues. But I'd say the early things that people should look out for is the high respiratory rate and the altered mental status.
Now, when you look at a group of patients with sepsis, are there different levels of severity with sepsis, or is it just, it's bad and that's it?
Yeah, well, the severity in sepsis is usually graded by how many organs you're experiencing dysfunction. So we mentioned shock, which is the blood pressure falling and not being responsive to fluids. There's renal failure, so the creatinine going up, the urine output dropping off. There is acute respiratory distress syndrome, where the lungs fail. There is, I mentioned, disseminated intravascular coagulation, where the blood starts clotting abnormally. And so the severity is really graded by the number of organ systems that are failing, and the greater the number, the worse the prognosis.
Right. So sepsis is not actually an infection, but it's caused by an infection. So we wouldn't call it contagious, or is it?
Now, by and large, sepsis is not contagious. Sepsis occurs in people with pneumonia, with urinary infections, with intra-abdominal infections. There are a few types which would be contagious. There's a particularly devastating type of sepsis called purpura fulminans, which is caused by a bacteria called Neisseria meningitis. Typically occurs in college age people. That can be very contagious. There's group A strep infections, which can be passed among family members and close friends. That would be considered contagious. Clostridium difficile colitis, which causes an infection of the bowel and organ dysfunction, that can be transferred. And of course, we've all heard of Ebola virus. But by and large, most of the sepsis that one would encounter in a hospital in the United States would not be contagious.
Okay. I'm talking to Dr. Stephen LaRosa. He's an infectious disease physician, and we're talking about sepsis. And now that you may have already answered this question for me, because you said 6% of hospitalized patients have sepsis. Is the number high because maybe this is being misdiagnosed or not recognized in a timely fashion?
Right. So I think it's the latter. I think it's not being recognized in a timely fashion. So it turns out probably about 70% of sepsis cases are people who come from the community and present to the emergency room. And by and large, emergency rooms are pretty good at picking up on this and intervening quite quickly. Where the problem is and with the higher mortality is somebody who comes in with an infectious illness, goes to a regular hospital floor and deteriorates, and the signs that they're deteriorating are not picked up in a timely fashion. And hospitals around the country, around the world have really clued into this and are all trying to work on what's called early warning scores. with a combination of lab markers and vital signs that will trigger to the bedside nurse and the treating physician that there's a problem, and that there's a problem before organ failure sets in. And places that have these early warning systems and scores are showing great promise. And so I think we're not picking it up in a timely fashion, but lots of places are working on this.
Yeah. Now, you mentioned a couple of bacterial causes of sepsis. What other microorganisms are most frequently implicated in sepsis?
Right. So when I think of the microorganisms, I think of what are the common sites of infection that trigger sepsis. So probably the leading candidate is community-acquired pneumonia. So the organisms that typically cause this are Streptococcus pneumoniae, or what's called the pneumococcus, Staph aureus, Haemophilus. So that would be from community-acquired pneumonia. Intra-abdominal infections are organisms that reside in the bowels. So these tend to be gram-negative organisms such as E. coli and Klebsiella and anaerobes. And along the same line, urinary tract infections, which are usually caused by gram-negative rods, and again, E. coli leads the list. There are skin and soft tissue infections, and the one that's probably most well recognized in terms of causing sepsis is Group A, strep. So gram-positive and gram-negative organisms. And then there's a smattering in people who've had lots of antibiotics and who are immunocompromised who get fungal sepsis. So sepsis caused by Candida, and that's a smaller amount. That's probably about 5% of cases. And then you'll get the oddball cases. But by and large, sepsis is caused by organisms that have been around for a number of years and are associated with focal infections in certain body sites, the typical sites.
Yeah. Dr. LaRosa, what are the risk factors for sepsis?
So when I think of the risk factors, I think of ones that you can modify and you can't modify. Sepsis certainly increases in frequency with age. So we know that as you age, your immune system you become more immunocompromised. So clearly age is a risk factor. Not much you can do about that. Cigarette smoking, because of the damage it does to the, obviously it does to the lungs and sets you up for pneumonia. Alcohol abuse, because we know that the liver and spleen are major immune organs and are a line of defense. And so having liver disease as a consequence of alcohol abuse, you'll see a lot of cases of pneumococcal pneumonia in that setting. Then in terms of people with pre-existing organ dysfunction, so having underlying lung disease, having underlying kidney disease, cancers and being on immunosuppression, having diabetes and not having your diabetes under control is clearly a risk factor, as is immunosuppression either from medications you're on or as a consequence of HIV infection. So some lifestyle lifestyle problems, as well as increasing age and increasing comorbidities in terms of your underlying organ problems.
Okay, we've got about 3 minutes left in the half. So if you start running long, I might interrupt you so we can stop. And
Okay.
Now, as a physician, what laboratory or other medical tests are most useful in the diagnosis?
Well, there's two types that I look at. One are labs that help you clue into the presence of a severe infection or bacteremia, and for those, I pay a lot of attention to the complete blood count, and not really the high white blood cell count that people focus on, but having a low lymphocyte count, less than 1,000, having a low eosinophil count is actually a marker of bacterial infection, and having a ratio of neutrophils to lymphocytes greater than 10 is also a marker of severe bacterial infection and the potential of bacteremia. Also, there are some biomarkers of infection that are helpful in predicting severe infections, such as a CRP, C-reactive protein, a protein made by the liver in the setting of inflammation. Having that greater than 100 milligrams per liter, or procalcitonin, which is produced by reticuloendothelial cells in response to bacterial infection. Having that elevated more than 2 nanograms per ml is a marker of severe infection. One also needs to monitor for organ dysfunction, and so having an elevated lactate is a sign of your organs being hypoperfused. So if you have a lactate more than the upper limit of normal, 2.2 millimoles per liter is a marker. Your serum creatinine going up, a marker of renal dysfunction. Your bilirubin and your liver enzymes going up could be a marker of early hepatic dysfunction. And having an elevated or prolonged prothrombin time and a low platelet count is a marker of severe disseminated intravascular coagulation. Platelets can go up early if you have a focal infection, but as sepsis becomes worse, the platelet count will drop precipitously and is actually a marker of poor outcomes. So I guess I look at markers both of gauging whether there's the evidence of severe infection and then also whether an organ is being impaired.
Okay, so we're getting close to the hard break, and I want to encourage listeners to check out Dr. LaRosa's blog. It's called My Thoughts on the Future of Infectious Disease in Medicine, and you can find that at drlarosa.blogspot.com, and I'll, of course, link to that when I publish the audio on the website, outbreaknewstoday.com. Let's go ahead and get a word from our friends at Global Lyme Diagnostics. For many years, we have been waiting for a Lyme disease test that actually works. After decades of research by Dr. Richard Marconi, a professor at the Medical Center at Virginia Commonwealth University, a breakthrough test has been developed. The GLD test, recently launched by Global Lyme Diagnostics, is based on Dr. Marconi's science. For more information, visit glymedx.com. That's glymedx.com, or email at info@glymedx.com. Dr. LaRosa, I want to go ahead and piggyback on some of your laboratory diagnosis testing that you were talking about, and go to your blog, My Thoughts on the Future of Infectious Disease in Medicine, and you did a piece just on the CBC, and you talked quite a bit about the CBC already, but in this blog post, you put a lot of faith in the CBC. And in the end, you say, make sure that you squeeze all the data from it that you can. Can you elaborate on that?
So as an infectious disease physician, it's quite common that I'll get called with somebody who's quite concerned about a patient's high white blood cell count, total white blood cell count, leukocytosis, or having a certain percentage of immature neutrophils called bands. And that's really what's driving the call. And it turns out that neither one of those findings in an adult is specific for the presence of bacterial infection or sepsis. And I sometimes feel when it comes to infectious disease, the physicians hone in on the total white count and bands and ignore everything else. And you could just wring so much useful information out of a complete blood count. As I mentioned, if your absolute neutrophil count to absolute lymphocyte count ratio, which is part of the normal CBC with diff, is greater than 10, that's actually a much better marker of severe infection and bacteremia than is a total white count. Similarly, if your absolute lymphocyte count is low, less than 1,000, that is also quite predictive of bacteremia. It's also interesting that people focus on total eosinophil counts when they think of drug reactions or allergic phenomena, but actually having a low eosinophil count, low total eosinophil count, is a very good marker of bacterial infection. So pay attention to the eosinophils. When you get to the red blood cell side of things, there is parameter that comes up in your normal CBC called your RDW, red cell distribution width, which is exactly what it means. It's the variation in size of your different red blood cells. And as that percentage increases, it's actually a very good marker of sepsis and impending organ dysfunction. So having a red blood distribution width of 15% or greater is quite predictive of severe infection and sepsis. On the platelet side of things, I think I already mentioned early on, if your platelet count is quite high, that to me has always been a marker of an infection in a closed space or an abscess. And that's an acute phase reactant, something that goes up acutely in the response to infection. On the other side of things, if your platelet count gets very low or you become thrombocytopenic, that's a marker of activated coagulation in DIC and is actually a very bad prognostic finding. So what I emphasize to people is pay attention to all three cell lines and all the information that you can get from a CBC and not focus just on the total white blood cell count.
Very interesting. Now, sepsis is considered a medical emergency, and so as an infectious disease physician, how do you go about treating someone with sepsis?
Right. So remember, sepsis is not just the infection, it's the host response and organ failure. So you are, as an infectious disease physician, you're just a member of a multidisciplinary team that cares for these people. But the very important part, there was a recent study that showed that having ID physicians as part of a sepsis team that responds acutely to someone with sepsis is associated with a lower mortality. And the reason I think is that it's becoming very clear that one of the most important factors in outcome is early appropriate antibiotic therapy. So getting the right drug, the right dose at the right time. And I think that's the role that an ID physician plays. And a lot of that is really honing in on what you think the site of infection is, since your empiric choice of antibiotics will vary depending on what the site of infection is, and also some knowledge of the antimicrobial resistance where you practice, and being able to select agents that are less likely to be resistant to the organism that the patient has. The other important role I think an ID physician plays in this is the issue of source control. So that's correcting the site of infection. So if there's an abscess, recommending that it be drained. If there's an obstruction of the genitourinary tract, that be relieved. If there's infarcted bowel or perforated bowel, that either be drained percutaneously or surgically. So if you don't control the source of infection, you can give all the antibiotics in the world. It won't change the outcome. And I think that's the important role of an ID physician, is pointing out the need for source control. And lastly, there's becoming an increasing array of rapid microbiologic tests. And I think the ID physician is well positioned to point out which of those tests could be most helpful in getting the right drug at the right time.
Now, I would imagine that part of the treatment would also be fluids.
Right.
And in your blog, you discuss IV fluid on a couple of times in different posts in quite a bit of detail. Can you share your thoughts with the audience about the IV fluids?
Yeah, so like a lot of things in sepsis, the whole issue of fluids has undergone a paradigm shift. So in the early 2000s, one of the things we appreciated was that early aggressive fluid resuscitation in patients with sepsis, particularly those with septic shock, those with low blood pressure, was associated with improved outcomes. So it really highlighted that we probably in the past had not been responding aggressively. However, I think we went too far in that we were going overboard. We were giving too much fluid. And what has been found is if you have an excess fluid balance, meaning you are taking in more fluid than you're putting out in urine over the first 72 hours, as that number goes up, your mortality actually goes up. So there is a harm in over-resuscitating someone. Flooding someone with fluids is not without its sequela. And so we've come full circle, and now what we're realizing is we have to aggressively resuscitate someone, but we have to do it in an educated fashion. And what I mean by that is we have to have some dynamic measures that tell you when you're giving fluid and someone's likely to respond, and when there's a point where giving more fluids is only likely to do more harm. And what people are using, there was a recent study of a non-invasive cardiac output monitor that measures stroke volume. That's the amount of fluid that your heart puts out with each beat. You can actually measure the response to the fluids you're giving, and if you're not getting an increase in your stroke volume, that means you're not really deriving any benefit from that fluid bolus, and you should stop. So what's being recommended now is you use not necessarily this one particular measure, but some dynamic measure that tells you if the patient is fluid responsive. And in that setting, you keep giving fluids until your measures tell you that they're no longer fluid responsive, and then you stop. So when you do that kind of strategy, it's associated with obviously people putting less fluid into their tissues and organs, being in the ICU for fewer days, needing less dialysis, being on the ventilator less time. So the goal is really resuscitate somebody appropriately, but stop when you're not going to get any further benefit.
Okay.
The other thing with fluids is there's now, I guess, an increased attention to what type of fluid. So typically what's used in the U.S. is what's called crystalloids. So they're usually composed of minerals. Probably the one most people are familiar with is normal saline, which is sodium chloride. There's also lactated ringers. There's plasmolite. And it was generally associated or thought that they're all alike. You just had to give enough fluids and the patient would be fine. But it turns out that not all these fluids are alike. So this normal saline, which has really been the standard, is really, there's nothing normal about it. It doesn't really represent what's in the plasma. It has a very high chloride concentration relative to what we have in our plasma. And that chloride may very well be causing kidney injury, renal artery constriction, and worsening outcomes. So there's at least 2 large trials right now that are looking at saline versus what we call balanced salt solutions, solutions that are more like our plasma, to really look at this. And it could really revolutionize the way we resuscitate people.
Now, I noticed on your social media account that you were involved with the only drug ever FDA approved for the treatment of sepsis. And correct if I mispronounce it, correct me. Zygris?
That's right.
Yeah. So what's the story behind that? Is that still something that's on the market?
Right. So Zygris, which was the brand name, which is the generic was drotrecogin alpha activated. What it is a recombinant version of an anticoagulant protein that we have in our bloodstream called activated protein C. And what the molecule was trying to do is replace what is deficient in people with sepsis and correct the underlying coagulopathy. And I was fortunate enough early in my career to be involved in studying this protein in patients with severe sepsis. And we did a study that was actually stopped early by a data safety monitoring board for overwhelming efficacy. It was a 6% absolute reduction in mortality, about a 20% relative risk reduction. Those numbers in critical care are huge, and the trial got stopped early because it was thought that it would be unethical to continue a placebo-controlled trial. And then the drug actually in 2001 was approved by the FDA, but there was a lot of controversy around it. One of the things that was clear was that the drug tended to work much better if you had a more severe form of severe sepsis, even of septic shock, than if you had less severe form. So there was a drug severity interaction, and there was also some bleeding risk because it was a recombinant anticoagulant. So there was some bleeding associated. And then the manufacturer, Eli Lilly, was charging what was considered at that time, wouldn't be considered now, to be exorbitant prices. So there was a big backlash against the drug, and the FDA required that the sponsor, Lilly, do a few confirmatory trials. And those trials actually didn't bear out the efficacy that was seen in the initial trial. And subsequent to that, Lilly voluntarily pulled the drug from the market, so it's not available. However, when Andre Khalil and myself looked at the real-world effectiveness of the drug in numerous both controlled studies and single-center studies, we found that the effectiveness was largely the same as that was found in the original trial that supported the registration. So a lot of us actually feel that this is a drug that was pulled prematurely from the market and likely has efficacy. The question is, can you pick out a certain group or population that it would work in? But I'm probably not alone in thinking that the drug should at least be resurrected and studied further.
And what would that take?
That would take a sponsor. Lilly has essentially abandoned the molecule. It sits on a shelf. This is a very complicated recombinant molecule, so it actually takes a distinct plant. You can't use any kind of manufacturing plant to produce this drug. It has to be specifically set up to produce this drug. So you need a sponsor, and obviously to do the trials in critical care that would be big enough to convince the FDA of its efficacy would likely be large and would require somebody to pay for it. So I don't see it anytime soon, but I'm holding out hope that we can get somebody interested in doing this.
Do you know of anything else that's in the pipeline for treating sepsis?
Yeah, there are lots of molecules in the pipeline. Interestingly enough, and what's nice to see is there's some emphasis now on sepsis-induced immunosuppression. Remember, for many years, it was thought that it was just a hyperinflammatory response, so-called cytokine storm, that was driving all of sepsis. And now what we've realized is that, in fact, there may be an early hyperinflammatory phase, but what a lot of patients die of is secondary infections because their immune system is, if you will, paralyzed, and they're immunosuppressed. So there's a number of agents in development now. Interestingly enough, one is an approved cancer agent, Opdivo, which is an anti-PD-L1 antibody that's being tested in sepsis. There's IL-7 that's being tested. There are also companies that are focusing on the pathogen side, so removal of pathogens from the bloodstream. But it's a fertile time. There have been so many failed trials in sepsis that getting funding and investment has been difficult because it's considered to be quite a quagmire, and there's been so many negative trials that there's a lot of cynicism as well as to if anything will improve outcome. But fortunately, there are still people focusing on it.
Yeah, it seems to me that the issue of sepsis, though, is becoming more and more visible, and more people are aware of it today than 20 years ago or 30 years ago when I first started in the business. So, now I understand that there's a condition that affects about half of sepsis survivors called post-sepsis syndrome. Is this a physical, psychological condition, or some kind of combination of both?
Right. So the other interesting thing that's happened in sepsis over the last couple of years is people are now starting to focus on this post-sepsis syndrome. So it was something that nobody really talked about. Everybody took great satisfaction in that we were saving people from sepsis, but we were creating and still are to some extent creating what I would call victims, not necessarily survivors. People with severe impairments, and their impairments from a psychiatric standpoint, severe anxiety and depression. Many of these survivors have post-traumatic stress disorder that's disabling. There's severe cognitive impairments, probably due to effects on the hippocampus. So people can't work, they can't think straight, they've lost their executive function. And then there's the physical. This is a catabolic illness, so severe muscle weakness and loss of respiratory muscle strength. So it's not only a physical, it's a psychiatric as well as a cognitive hit. And this occurs even in young, previously healthy people who get severe sepsis. You'll hear these horrific stories of how they can't function and work anymore. And I think to the credit of SCCM, there's been a lot of focus on let's do studies to see if we can actually impact this syndrome.
Now, are there any preventive measures for sepsis?
Well, preventative measures for sepsis, I should mention that there are being some preventive measures to try to prevent this post-sepsis syndrome.
Okay.
And actually prevention is better in preventing the post-sepsis syndrome than actually dealing with the sequelae. And what people are trying to do is we've learned that if you try to have light or just minimal sedation while somebody's in the throes of sepsis, that's better than what we used to do years ago, which is we used to snow people. They'd be fully under for the whole time they had sepsis, and that was met with significant cognitive and psychiatric sequelae. Spontaneous breathing trials, so even if someone's on a ventilator, turning down the settings at different time points during the day to actually exercise the respiratory muscles, actually getting people on the ventilator up walking around while they're on the ventilator so as not to get muscle atrophy. That's something you would have never seen 20 years ago, but you see that now, and so the patients are not as disabled as when they get off the ventilator. And then preventing low glucose and low oxygen. Those are all things that prevent post-sepsis. But to answer your question about preventing sepsis in general, there are some things that can be done. From a lifestyle perspective, certainly cigarette cessation and alcohol in moderation, thereby preventing lung and liver dysfunction, respectively. That can be done. Controlling diabetes mellitus, and other comorbidities. And then vaccination. We see a lot of sepsis as the result of pneumococcal pneumonia in people who have not had a pneumococcal vaccine, people who don't get an influenza vaccine. Severe influenza is associated with 30% of patients who get a secondary bacterial infection, and a lot of those get septic. So vaccinations, meningococcal vaccine in college-age students who are going to be close-quartered in dormitories certainly is protective. People who have MRSA colonization, decolonizing them so that they don't get recurrent skin and soft tissue infections. Those would be just some of the preventative measures.
Excellent. Now, about a month ago, I did a podcast interview with a lady named Mary Millard, and she got a Pseudomonas aeruginosa healthcare-associated infection and sepsis, and her story is really something. And I asked you to see if you could get a chance to listen to her story, and I wanted to get your thoughts on it. Did you get a chance to listen to it, Dr. LaRosa?
Yes, and it was quite telling for a lot of reasons, because I think she really hit on.
I got about 2 minutes left, sir.
A number of important points. One is the importance of infection control practices in the hospital, making sure that physicians are washing their hands, that there's good surgical technique. She hit on the post-traumatic stress disorder of survivors and how impaired their lives are, and really emphasized the need to focus on those issues. Antibiotic side effects, being able to give the right drug and really trying to manage the side effects of those drugs. And then she also mentioned early on in her course the importance of of picking up on the diagnosis of sepsis very early on. And that's something I mentioned with the early warning score. So a lot of her story, I would just say she hit on a lot of the important points.
Yeah, I thought it was quite a story, and she's become quite a advocate for sepsis. I guess I'll wrap it up there. Thank you very much, Dr. Stephen LaRosa, for your time and expertise and a wonderful interview on sepsis. I appreciate it.
Great. Thanks for having me on again.
You bet.